Fabulous. Okay, thanks everybody, and welcome to this last session for today on health politics, the politics of health. I'm Margaret Blakers from Australia, and I'll introduce our three panellists in a minute. And I can't really see you all, but anyway, welcome. And and I'm sorry we're late, but the previous session, I hadn't realised, ran through till 6:15, so I just needed to give everybody a little bit of a break. So we'll finish on time, and at 7:45, I think that's right, yes, in an hour's time from now, there'll be an update on the Global Greens resolution, so anybody who's interested in that should stick around, and everybody else can go and have a drink. So this is going to be a pretty freewheeling sort of session. I know almost nothing about health except my own. And I think, it definitely is the first time we've had a plenary session on health at a Global Greens Congress. And I guess that's at least partly because it's normally considered the province of national or state or local governments. But clearly health, like many other issues, has global dimensions, and the question is how we should address those as well as the issues at other levels. The three panellists here, now we did have a slight problem with this session, which became rather beset with bad luck or ill health or both. One of our panellists actually became ill and couldn't travel. That's Margot Soria from Bolivia. One lost a passport and one failed to get a visa. So I'm particularly grateful to Ratafika for stepping in at the last minute to help us fill out our panel. And as I said, we're going to just have a very informal discussion, and I would like you all to be part of it. There are microphones on either side of the central aisle, central bank of seats. And we also have a social media feed, which so questions that are coming in through that mechanism will be asked as well. So keep your questions short, keep your comments short, and let's have a very entertaining and interesting and insightful discussion. So our three speakers, Ratafika Dimbindraiba, possibly, who's a medical doctor, formerly Vice President of the Young Greens of Africa, and a member of the political bureau of the Green Party of Madagascar. Next, Richard Di Natale, who's a senator in Australia, leader of the Australian Greens, and is also a medical doctor and a public health specialist before he entered Parliament, with experience in Aboriginal health, HIV prevention, and drug and alcohol issues. Suzanne Nordling, who is a county council commissioner in Sweden for the Green Party for the last 2 or 3 years. And she is, she's been politically active on the local level in the city of Solna for the last 14 years, including being Vice Mayor and Vice Lord Mayor, and has also had experience on WHO. And the Stockholm County Council is responsible for 2.2 million people. So it's quite a large local area. So I'm going to ask each of our speakers to start with just a short 3-4 minute presentation. And the question I've asked them to think about or to talk about is, what do you mean by health? What is health? What do Greens mean by health? And what do you see as the barriers, political and otherwise, to changes that would improve health and healthcare for people at any level from local to global? So that's a rather large subject. Pick whichever slice of it you want, and perhaps I'll start with Suzanne. Yeah?
Hello, and thank you for participating in this panel. First, I would like to say the best patient is the one that doesn't need healthcare. But how do we get there? Of course, we can start with clean air, water and soil, because we are also a large part water and a lot of nutrition that comes from the soil and the trees and the plants and the sun. So, of course, what happens in the environment affects us and the diseases that we have. From there, we could go to how we build our cities, how the infrastructure is built, how the green structure is built, the social structure, mobility in the cities. Will that structure promote health or not? So if we would work green for health, then we would think to build our cities not for cars, but for the people who are living in it. And when we work with the infrastructure in that way, we should think of it out of the perspective of the child. Because if we work with the infrastructure out of the perspective of a child, we make it more secure, more accessible, also for elderly people and people with disabilities. And it becomes more environmental friendly. So what will we decide if we make a decision how to build? For example, we would make the child resolution by WHO law in our countries, and we will start to plan our cities and see how the child resolution can affect the plans. And we would involve children. By that, our cities would become more safe and also more environmental friendly. So if we also see on other green factors that's within our ideology is gender equality. It's equality. We should not have social gaps because that will not be in favor of our health, and it will not be in favor of how long we live, life expectancy. Education is also very important for health. And these factors, they have the most significant impact on the most widespread diseases that we have in the world. Social inclusion is also very important for health. So that's also something that we have to work with to have a healthy society for all. I think I stopped there. I have some examples, but I stopped there, and then we'll have a talk later.
Thank you. So I think the World Health Organization defined health as not just the absence of disease, but actually a state of physical, psychological and emotional well-being. So, I mean, that's, I suppose, your textbook World Health Organization definition of health. The more interesting question is, how do we actually achieve that? And I think the thing that separates our view of health from where we see the mainstream health debate is that we recognise that health is not just something that comes about because of your genetic endowment. It's not just something that comes about because of the choices that you as an individual make, but it's the end result of a whole range of social determinants and environmental determinants. As Suzanne said, the level of education you have, employment, access to health infrastructure, all of those things are a very direct, or have a very direct impact on the health of individuals and the health of a community. The environment into which you're born, access to clean air and clean water. So I think that recognition that health is actually this end product of a whole range of things that are happening in a person's life is really what in my view, what it means to have an understanding of healthcare from the perspective of being someone involved with the Greens. Where we talk a lot about inequality, we talk about it because obviously there's a serious moral dimension to the problem of inequality, and most of us are motivated by that sense of injustice, but inequality is also a health issue. We know that societies that are more unequal have worse health. We know that that's independent of the level of GDP. So, for example, we can have high-income countries with high levels of GDP, but with significant degrees of inequality that actually have poor health outcomes compared with other nations with lower levels of GDP, but in fact with lower levels of inequality that have higher or improved health outcomes. So inequality is also a very clear determinant for the health status of a community. I would argue that climate change isn't just an environmental, economic and social problem, but it's a health problem as well. We know the impact that that climate change will have on our health systems, our capacity of our health systems to be able to respond to the needs of people as a result of extreme weather, and a whole range of other things like vector-borne diseases, and we will see very different disease patterns as climate change progresses. So I suppose the key thing for me to emphasise is health isn't just about that notion of personal choice. It's not just about the genetics that you might have that predispose you to certain conditions. It's about the world in which you're born and the circumstances that will ultimately influence your life expectancy, what illnesses you're going to be exposed to. And for those of us as Greens, if we want to improve the health of a community and individuals, we can't just look at the health system. We need to look at all of those social and environmental determinants as well.
Yes, I'd like to say good afternoon. And on the subject of health, my brother and sisters have already said that health means mental, physical, social and economic well-being of the individual. In order to ensure such well-being, clearly what is required is to provide a healthy environment, or milieu, to each individual. I'm trying to look at this from the global, planetary, world level. The environment is an absolutely basic, key requirement for the health of human beings on this planet. Now, currently, medicine is changing greatly. It's being transformed, and in terms of health, we have medicine to treat, to cure those who are sick. But for some time now, we have been also seeing preventive medicine, its existence. That is medicine that can prevent the opposite of ill health, which is well-being. Now, we Greens attach greater importance to preventive medicine than curative medicine. So our position is based around the environment, and it must ensure a greater importance for this type of medicine, preventive medicine, as I said. So I think from this point of view, we face a responsibility, and the entire planet is awaiting our fulfillment of it, so that humanity can attain good levels of health, and this requires us to work a great deal on the environment and around the environment. Now, for decades in the less developed countries, poor countries, the rate of mortality amongst children linked to pollution, particularly water pollution, hasn't stopped soaring, in fact, and the World Health Organization has said that every 10 minutes a child dies because of acute diarrhea. And amongst the pathologies, new types of disease, cancer, tropical and infectious diseases, they ceaselessly are killing people because of the deterioration of the environment and climate change. So this is why we Greens, particularly in Madagascar, have been working on a green health reform platform centered around the environment, which will impact on everything concerning health.
Can you give me one of the microphones? Okay, I'll just ask anyone who's interested in asking a question to come and queue up behind one of those microphones. But also, just while people are thinking up their questions, so Ratafika, can you be a bit more specific about what would be in the health policy for Madagascar? Some examples.
Okay.
Well, in terms of well-being, as I explained just now, what we mean is a healthy mental, physical, economic and social state, and a lack of well-being means quite the opposite. So in Madagascar, we are faced with a greater battle because on the one hand, currently the country is really experiencing the grip of socio-economic crisis. So this health policy, well-being policy, is difficult to attain currently, but we are determined to find the means to attain it. And we have a health reform bill centered around the environment, which we are trying to submit to Parliament, and we're constantly campaigning in the different urban centres around it.
Okay, so on the left hand, or my left.
Thank you. I'm Laura from Green Party of England and Wales. We as Greens support environment, but we also care about inequality and we care about human rights. And I think it would be short-sighted to view health as Greens only in terms of what we can do by improving the environment. The huge elephant in the room, to me, is that in many countries, health services are not provided at any adequate level because of extreme poverty and a great lack of resources at the government level. That can be for internal reasons because that country isn't collecting taxes as they should, but often it's for global, international and historic reasons that have entrenched poverty and low incomes nationally and personally in many regions of the world. So I think it would be absurd to try and talk about what we can do about global health without talking about how we can redistribute global wealth. And that means taking a hit in richer countries so that basic human rights to healthcare can be provided worldwide. And Ratafika, I hope that you feel empowered in Madagascar and other countries that are suffering socio-economic crises that make them unable to pay for healthcare. I hope you feel empowered as the Madagascan Greens to demand the resources that you need from the international community because they are owed to you as a matter of human rights and historical and global justice. So that needs to be part of this conversation.
Thank you. Anybody would like to comment on that? Okay, let's go this. Oh, you take that one. Yeah, thanks.
Okay, I come from Sweden and we have public health care, but still we need to work with that. All of Europe, we can travel to other countries, and if we get ill when we are visiting France or when we are visiting another country, we can get health care within that country. So we have like a blue card for health within Europe. But still we have to work with the wide door into healthcare, and that's primary care. And I think for the Greens, we need to work to try to find ways to have a state-controlled primary care, healthcare. Because if healthcare is there, primary, it's a security for the society. It's a security for to know if I get ill, I know where to go. So it provides a more secure society. It provides a more, health for everyone is the goal. So primary care it's really crucial for that. And for people to know that they can go to the primary care and get help, not when they have their heart disease, but are already very ill, but they can go there when they feel a little bit ill, it's a securing issue. So I think that's what we have to try for in all countries.
Okay, thank you. Person on this side?
Yeah, Chris Philpott, UK Green Party, England and Wales. My wife is a homeopath, and one thing I've learnt is that the Greens, especially in UK, have supported types of health treatment like homeopathy, herbalism, which are not based on a pharmaceutical model and gets out of that loop of making profit, and it's accessible. I'm thinking of some of the speakers, have they looked at the Chinese model where they are using acupuncture in hospitals and where they use Chinese herbs as part of their treatment? Do they see that we have to follow a conventional pharmaceutical model when it makes a lot of profits for the pharmaceutical companies, and they get a little foothold in these health systems in the country? I'm wondering how they feel about that, how they think about that.
Thank you.
So I agree with you that there are huge issues with the dominance of the pharmaceutical industry, for example, in biomedicine. I think the core principle for the Greens is one that has to be founded on a couple of things. One is choice for individuals to be able to choose the healthcare that they feel best meets their needs. And I think the second issue is when it comes to government funding of whatever universal healthcare model that exists within each country, is that has to be based on evidence. Now, one of the issues, of course, is that that often the evidence is dominated by large interests, big corporations, pharmaceutical interests, and so on. And we need to ensure that we provided more funding for as public institutions that are able to do research independent of that pharmaceutical model. But nonetheless, evidence is absolutely critical. And there is actually, very strong evidence, for example, around acupuncture. You mentioned acupuncture for a range of conditions. In Australia, we're having a debate around medicinal cannabis, where the Greens have led the charge to have medicinal cannabis provided for a range of conditions for which there is evidence. So I think that principle of when we're going to fund through the public purse any healthcare intervention, it has to be on that principle of evidence. But of course, that shouldn't change the fact that individuals should feel free to choose whatever healthcare intervention they feel meets their needs.
Suzanne, and then I might actually broaden it out to the question of traditional medicine, since that was part of the question, and I don't know whether Ratafika, you might have a comment on that as well.
I agree with Richard here. When it's state-funded, it should be based on evidence. But World Health Organization realized, like 25 years ago, that they needed to start to work with traditional medicine. They realized by a survey to all the departments of health around the world that about 80% of the world population was dependent on traditional medicine for primary care. So they decided that they have to work with this issue. They have to make recommendations, resolutions, guidelines for the governments around the world how to regulate this area. I have been part of that expert committee for 8 years, 2002 to 2010. So there are guidelines done by World Health Organization in cooperation with all governments around the world, guidelines for education in Ayurveda, Unani, acupuncture, Tuina, Nuad Thai, naturopathy, chiropractic, so herbal medicine. So there are guidelines out there how to regulate this area. And that's really necessary because even though it's a freedom of choice for the individuals to go and pay their own money for this, it needs to be patient safe. It needs to be according to certain educational levels. You need to have a knowledge of when not to treat a patient, so you can make a differential diagnostic and send the patient to the medical doctor because this is over your level. And there has to be ethical rules also for them. And all this WHO has worked with during the last 15 years. And I think that's a good thing.
Je continue un peu ce que mes collègues ont expliqué.
I'll pick up on the explanations my colleagues gave just then. I mean, yes, of course, it is true to say that in poor countries we don't have the necessary means to actually cover health for every individual. That is a fair comment. Now, as far as the WHO is concerned, we know that the WHO has already drawn up a number of health rules, rules that have to do with traditional medicine, and rules that have to do with the use of herbs, natural plants, to treat patients with. As far as Madagascar is concerned, at the moment, we already have a law, in fact, a law which is in effect and which does authorize healers to use this, and what we call the matron. So these are women who are able to, for instance, help with a natural birth. They too are authorized. Now, of course, these individuals need to be trained. They receive training with medical staff, in fact, certified medical staff. And then after that, once they've completed their training, they are issued with their certificates. And there are a number of legal procedures that have to be followed. And from that point onwards, they can practice. There's also pharmaceutical laboratories and homeopathic laboratories where they're working with plants, where they're working with traditional medicine, and all of this has been licensed by the government. It is authorized by the government. And that's why I would like to share that example with other countries, because other countries may be well advised to look into these techniques, look into these options in order to come up with a solution and in order to be able to care for all our patients, to cover them. And also, I think it would be good for, covering people, particularly people who don't have means and will therefore have nothing to pay either, who can't pay. I mean, in Madagascar, like in other countries of the south, we have a lot of medicinal herbs, medicinal plants, and so it's much more accessible than pharmaceutical medicines, the usual medicine. So it's actually really helpful, particularly for people in poor countries. Our sister, I think, was asking about that earlier on.
Thank you. Okay, over to this side.
I'm Stuart Jeffrey. I'm a former health spokesperson for the Green Party in England and Wales. I've heard a few of the global problems that we've got, such as climate change, inequalities and air pollution, and I've heard a lot of local solutions, and they're all great. But I suppose the question is, what are the global solutions? What should we be doing collectively as a planet to tackle the health impacts of this? Or is or is it just a local response to global problems? I'd like to hear what great ideas we can do as the one people across the planet.
Who wants to pick up on that one?
It's a very big question. I suppose it depends what, if for example, you mentioned the issue of climate change. I mean, we all understand that climate change is an issue that requires a global response. I mean, that's what the Paris Agreement was all about, and coming up with the architecture that allowed us to set our own domestic targets and pathways to get there, but ultimately it required a coordinated global response. One of the issues that hasn't really been mentioned yet, but is potentially one of the great public health challenges that faces us over this century is antibiotic resistance. And we're seeing the emergence of antibiotic-resistant organisms that have the potential to really turn decades of progress around. And in fact, some people are arguing we may be entering a pre-antibiotic era. And for those people who wonder what that means is, you know, the prospect of people dying because they get simple infections that were easily treatable with antibiotics when they were effective. That requires a global response, because that's a combination of the overprescription of antibiotics in clinical practice, but more importantly, the overuse of antibiotics in intensive animal agriculture. And like many of our problems, they are global problems. So we're seeing, for example, some of these superbugs cross transnational boundaries and coming to, well, basically being communicated right across the globe. And unless we get an architecture that sits above what each country is doing around how do we prescribe antibiotics, what's the appropriate framework. We still know that there are many nations that allow people to go to a chemist, pick up a packet of antibiotics and use them according to their own discretion. We don't have a regulatory framework that is accepted globally, and we need one. The same thing applies to the use of the overuse of antibiotics in animal agriculture. So absolutely that requires a global response. I mean, the bigger question is, how do we get there, and what is the role for those of us in the positions that we occupy? And I mean, I think in large part what it reflects is a failure of many of the global governance institutions that are meant to help us put that framework in place. So it's a huge challenge. It's an enormous challenge. Then there's the question of what our health systems actually look like, and what are the key principles around the development of health systems, particularly in low-income countries who are building those, and that requires the transfer of knowledge and skills from nations who have experience in those areas, and what are the key principles that underpin what those health systems look like, universality and so on. How do we create models that we can adopt around the world? Big challenges. I don't think I've got any easy responses for you, except to say that that we're a party that understands that the dimension to all of these issues is a global one, and it does require a global response.
So have you got specifically something you want to say? Otherwise, yes, go.
I think I would like to tell you a little story. I had the opportunity to go to Naples a year ago, and Naples had just had an earthquake, as you probably all know. And one thing that happened after that was a big boom for mobile phones. Because after the earthquake, you could not phone your relatives or your children or find them because the phone lines was down. But mobile phones that fly so in the air, the signal, you can have in countries where there are a lot of mountains. So mobile phones suddenly become a very important item for a child, for somebody who is not in the same city as yourself, in your family. And that's how developing countries can do technological leaps and skip some of the mistakes we have done in Europe, for example. And that means also, because of the World Wide Web, e-health is a very good way to capacitate people around the world about how to prevent diseases and how to keep a good health. So suddenly, the World Wide Web is opening up the knowledge to all people around the world to have knowledge to take their health in their own hands. And I think that's one way to try to get the information out over e-health.
Did you want to comment, or should we go on to the next question? Whichever you choose.
Yes, I'd like to continue then along the same lines that you were discussing medicine. As I was saying before, means taking care of people from the point of view of the disease that they're suffering from. So in order to be able to ensure if an effective care globally, as our brother said, involves long-term work. Why? Because many factors come into play which are very different, and sometimes very paradoxical situations arise between the north and the south. In the north, health problem amongst children is basically obesity, but in the south it's malnutrition and famine. So disease triggered by obesity is totally different to that caused by malnutrition. To take another example, for some time now we've seen the emergence of new disease related to radioactive pollution, cancer caused by pesticides. Also, so there is also a separation here between north and south. So a great deal of work is required to come up with a global solution. So this is why I did say that what we're talking about here is long-term work. That said, it is possible to come up with a solution if we work on that immediately. And I think it's really the Greens who can do this based on training amongst medical staff, as I said just now, eco-medicine linked to ecology. In the past, we used to treat infections using antibiotics, and as my brother just said, there are all sorts of secondary effects, but allopathy is based on the treatment of contamination within our body, our organism. So this is really something extremely positive that we are able to ensure, to bring about through campaigns, but at the same time we do need to continue battling around environmental protection and against GMOs and pesticides. Major industries and companies produce so many chemical products whose content we are unaware of, but when they're analysed, we don't always know the content. So what's required is the work of experts, and the content that they discover needs to be published So that really is a task that we have to carry out. It's already it's a step that's required in terms of achieving health, in terms of caring for people. Thank you so much.
And this side, I think, yeah.
Hello, my name's Richard Haines, and I'm a new member of the Green Party, about 3 months old now. Thank you for putting this session onto the agenda. I'm really glad that you started with a very broad definition of health and the World Health Organization definition, which I really like and recognise, not just being about physical but mental and social well-being. But one way that I think it can be improved and extended is to recognise the social model of disability, because sometimes, health conditions that we have, they can be long-term and not necessarily something that we can actually fix. And then the psychology that has on people where you are living with a long-term condition and the sort of maybe pain or anxieties that creates. My professional field is working with technology in health and social care also. And I became aware several years ago of personalised music. I watched a film on television on Russell Howe Good News on the BBC. And I thought that's too good to be true, really, for somebody with dementia who's in a dementia setting to be able to listen to music that they have a preference for and then suddenly start talking and acting as if they're more present with you in the room. I didn't believe it, quite frankly, and was very sceptical. So I thought I'll try this out for myself. So I volunteered. Although I'm a UK ambassador now for Music and Memory, it's a very small part of what I do, so I thought I'll try it out. So I went into a care home. I sat down with this wonderful lady, Bessie. I spoke to the brother. Bessie couldn't talk initially when I met with her, but her brother, Paul, had given me some background information about where she grew up, which dance hall she went to, what music she really enjoyed, and I put together a playlist on an MP3 player, and she started to talk, answer questions, and came alive again. And there is a documentary called Alive Again about this. And the question I've got, because I've had 10 years now working in health and social care settings, is reform is very, very challenging. And this is in the context of where medication is important and compliance with medication is important, but we know there's a problem, which seems to be a recurring theme, with or overuse of medication. There's a 2012 study that showed GP litigation was, it was 30% or 25% was associated with misuse or misprescribing. How can we make better use of things like music or other interventions where, the evidence is overwhelming? There's very rigorous, high-quality systematic reviews. National Institute for Excellence in the UK recommend it. How can you get it as simple as prescribing?
Okay, thank you very much. Anybody like to pick that one up?
So let me go to the first point about the overuse and misuse of medicines. I remember learning a lot from a doctor who, when I was training, used to visit patients in care settings and took great joy in ripping up medication charts. Often, people, will see a doctor, they'll be prescribed something. Often they'll be prescribed it for a short period of time, they'll be on it 3 years later. There are all sorts of things around drug interactions and so on. It's bad for the person, it's bad for the public purse, and there's no question that the medical profession needs to get better at actually reducing and in many cases just stopping medications that are being prescribed for no good reason. So what you've, I think, identified is something that is a broad problem, and it leads to all sorts of issues in care. The next part of, I think, what you talk about is recognising that, going back to that World Health Organization definition, health is much broader than just this sort of biomedical, we'll give you a tablet and we'll fix it. Part of it's about connection, and I think, in large part, many, for want of a better term, alternative therapies and complementary therapies, much of the benefit is derived just in that simple act of connection, in sitting down with the person, listening to their story, talking through their story, understanding their context, and that in and of itself is therapeutic for many people. And that, again, I think the medical community needs to get better at recognising that part of the problem is we've created this sort of conveyor belt sort of delivering medical care. And yes, there are so many, you know, options that we know work: art therapy, music therapy, all of which have huge benefit, which we sort of fund a bit at the edges. We don't do enough to sort of bring into the sort of mainstream healthcare, not medical care, but healthcare. And again, evidence shows very clearly that it does have significant therapeutic benefits. So we've got to get better at funding those things that we know work, and recognising that another pill, another tablet for something that isn't necessary and often will be short-term is a model that we've developed over time because it's served us well, but does have a cost. And that's a big cultural change that needs to happen. I don't know that there's, I mean, the levers aren't just sort of political and regulatory. There's a big cultural change that needs to happen in the way that we deliver healthcare.
Okay, so I think what I might do is just take one answer to each question, unless somebody's got a burning wish to intervene, so that we can hear from the other questioners and just move things along. So on that side.
Hi there, Nick Brooke, Green Party England and Wales. How can we reduce the profit motive in drug research and development internationally, particularly in the case of, for example, antibiotics, as you mentioned, because the profit motive is decreasingly effective in producing new antibiotics as they become less effective very quickly?
Mm-hmm. Go for it.
Well, the problem now is, you know, it's much more profitable to invest in research that's going to put somebody on a blood pressure tablet that they're going to take for the next 20 years that really has marginal benefit over what's already on the market, compared to antibiotics, which by definition you give to someone for a week and they're better. There's very little money going into antibiotic research right now because the motives, the incentives are all wrong. How do you fix it? Well, you've got to invest in public research. You've got to make sure that there is government-funded public institutions that have the wherewithal to do that. And then we've got to start thinking a bit more creatively. Do we need to look at levies or other ways to capture some of the work that's being done in areas to pathologise conditions, you know, whether it be, you know, there's billions of dollars being spent on hair loss, which is, you know, a normal part of the ageing process for a lot of blokes, and you know, very little, not just to antibiotics, but I mean, my colleague here, you know, tuberculosis, malaria, conditions, diarrheal diseases, all conditions which have a much greater burden of disease. There's a rule called the 90-10 rule, which is that 90% of research dollars is invested in 10% of the health burden around the world. And so, yes, there's a lot of work being done to look at what our alternative models look like. The number one thing is a greater investment in publicly funded research, and also looking at whether we need to turn on its head this idea of you only get incentivised to you know, develop a pill, a tablet, a treatment for a condition that has, you know, very little health impact. But you put your finger on a really, really important problem.
It's also how we pay for the service of the doctors. If you have a primary care facility and the reimbursement system is paid out to the doctors according to how many visits the doctor has, then of course the system will start to produce more and more interactions with the patients. But if you have a reimbursement system that has a goal instead, so that the patient, that the doctors has to work within the geographical area where they are working, with the health of the people and preventive care, so they don't need to go into the clinic, and that the clinic has a bigger amount of money, budget, that's not according to how many visits the patients do, but instead how healthy they keep the patients, then you get a new, different way of paying for the doctor's service with the tax money. So that could be like a carrot to keep the people in your geographical area more healthy and work preventive. I think that's something you can work with also locally.
Okay, thank you. Over to this side now.
Thank you. Sonia Reid-Smith from Third World Network. In addition to the areas of health that can be harmed by trade and investment agreements that were listed in the program for this session, there are many other aspects of health that can also be harmed by these treaties. For example, in the TPP's 30 chapters, more than 10 can harm health. For example, we heard about the importance of the affordability of clean water for health, but in a number of countries, when they privatised their water, it became unaffordable and unclean, so some governments tried to reverse the privatisation and then they were sued under these investment treaty provisions. Or if you want to regulate the affordability of services, whether it's hospital services or services that contribute to health like water, mass transport, this can be prevented by the services rules being negotiated in the WTO with 164 countries, the Trade and Services Agreement, RCEP and so on, and it's in CETA. Or if local governments want to use licensing fees, as they do in some countries, from bars or restaurants to pay for community health clinics or rubbish collection, this can be prevented again by these trade negotiations. And the last example is we know that pacemakers and nuclear power stations have been hacked, and cars can be hacked to stop the brakes working. And in the WTO negotiations on e-commerce at the moment, the European Union and other countries have proposed that governments cannot check the software in pacemakers, insulin pumps, hospital equipment, nuclear power stations, cars, to make sure that they cannot be hacked. You just have to let it go onto the market with no checks. So I was wondering, since the US had a proposal that was equivalent but had a health exception, how come the EU proposal has no health exception? How did that get through? How did DG Health agree to it? How did the Ministries of Health in the EU member states agree to it? Were they not consulted? If they were not consulted, how could they not be consulted on something that has deadly implications? Thanks.
Okay, we've only got one person from the EU here, so I guess that's you, Suzanne.
I don't have an answer to that. I'm working on the regional levels, so actually this question is too big for me, so I can't answer you that. I'm sorry.
Okay, well, we'll take that as a timely warning to be careful what cars you get into and what other machinery you are involved with. So over to this side.
Hi there, Tom Beckett from Oxfordshire Green Party in England and Wales. I also work with the Wildlife Trust. I suppose my question really is about how you see the natural environment playing an important role in people's health for the future. And it seems obvious to us, but even in our country we have challenges looking after green spaces for people. And there's clear evidence that musculoskeletal, mental health, obesity are all linked with not having access to green space. You know, there's clear evidence that if you live within 2 kilometres of a green space, you're going to be healthier than if you're further away or in a city. And we have 70% of the world's population will be living in cities by 2030. So I suppose my question is, like, how do you incorporate the kind of needs for green space and for nature into a kind of policy framework, and whether you see that important or not?
So I'm going to ask Ratafika if you'd like to comment on that one first. And then Suzanne probably has something to say.
Oui, pour les pays.
Well, for developed countries, European countries or the United States of America, yes, of course. We're talking about the big cities and they don't have much green space, that's true. But if you're looking towards developing countries, there you still sometimes find green spaces, even in city centres. Having said that, there are now techniques, and I've seen this even in developing countries, there are techniques to create what we call gardens or, agriculture, urban agriculture. So urban gardens and urban agriculture. And people are trained in how to do that. They'll take even a tiny plot of land and they'll create a bit of greenery there, either in a courtyard or maybe on a terrace, using those methods. So urban gardens. You might just need a bit of, a pot of paint. You put a bit of soil in that, you plant a flower in that, and that's it. You might have 3 or 4 such pots, and that already gives you a bit of green space on a terrace, for instance. And all of that is, I think, an effort that we need to sustain, we need to practice. I think it's in our hands, it's our responsibility. And as we move forward, as we make progress, even if, the governments or the cities or the mayors of the cities don't actually go about finding a green space actively, even if they, don't draw up plans or laws for the creation of green spaces, well, we can take ownership. We can do it ourselves.
Et autrement?
Sorry, can I add one more comment? Apart from green spaces, there's something else. There's therapy. Using soil or the land, using seas. There's what we call balneotherapy, so using the seas and seawater for therapeutic purposes. That's important for people who live by the coast, by the seas. Another solution, and it also allows us to preserve our seas, to avoid marine pollution, maritime pollution, and it's a form of therapy. So these are natural elements I'm talking about that we can use, and there's no medical bill to be footed at the end of the day.
University of Agriculture in Sweden has done some research about how to make the green structure and what you need to have a good health. And they have said that they have seen in their research that you need to have some green just around the corner where you live, exactly just 2-3 meters outside the door. You have to have something green close to where you live, even though you live in a high building. That you can see some green when you look out, so don't build too high buildings. You need 300 meters to a city park, so you can walk there. You can play football, or you can talk with people. It doesn't have to be nature, it can be a city park. But you need to have recreation area, more nature, so to say, with a little bit less than 1 kilometer away. So you can go there for recreation, to run, to whatever you want to do. How you plan your city will also have and the green structure will have an impact on the health of the people living in that city. And there are also research done about how the green affects a person when they are ill. Even if you only have a poster of nature in the room at the hospital, that will be in benefit for the person who is lying in the bed.
Okay, so we've probably got time for 2 more questions, and I'm going to ask for people who are not from the Green Party of England and Wales. Have we got a couple of people in that category? This one? Yep. Okay, this side? Yep.
I'm first. My name is Agneta Granström. I come from the north part of Sweden. I'm a regional councillor with responsibility for healthcare. And I have a question to Richard, because I saw that you were responsible for the healthcare of the indigenous people and that you were a specialist. In the northern part of Sweden, we have the Sami people, also in Norway, Finland, and Russia. And I'm interested in how you work with the Aborigines, as was presented, and how you deal with the health services when it is far away.
The first thing I'd say is don't do what Australia's done. I don't want to share any lessons from what we've done, because Australia has a very, very poor track record when it comes to Indigenous health. Yet I spent a few years working in some remote Indigenous communities. It's basically you're confronted with conditions that don't exist anywhere other than the poorest parts of the world. You know, young kids dying from things like rheumatic heart disease and so on. And all of those things can be attributed to effectively living in developing country conditions. We know what the principles are. We know what some of the key principles are. The first thing is ensuring that you've got a health workforce that is controlled and run by Indigenous people. So in Australia, we're building an Indigenous health workforce, Aboriginal health workers. We're now starting to see many of them become nurses and doctors. And it's absolutely critical, particularly because of the big cultural differences that exist, that healthcare is being delivered by Aboriginal people. So ensuring you've got that workforce is really important. It's also absolutely critical that you provide the services in a context that's appropriate. You can't provide them in hospitals, you can't provide them in environments that Indigenous people are not likely to attend. You've got to recognise that, for example, in Aboriginal communities, there are very clear roles for men and women, so the health services have to be culturally appropriate and gender appropriate. So delivering women's services being delivered by women for women, the same for men. So that's really important. Early intervention is critical, and it's really important that you're able to identify problems when they first begin. One of the easiest things to address in Aboriginal health that we still haven't done properly is ear disease. Chronic ear disease remains a problem in Aboriginal communities. It starts the moment children are born, repeated ear infections. It leads to hearing loss. That hearing loss affects language development, it affects learning, and it compounds right through the life of a young Indigenous person. So making sure you intervene early and in the right areas. There, I think, some key principles. In those remote areas, you can still provide those healthcare services if you train the workforce and you ensure that you're providing the services in an appropriate area. But I just go back to the point I made when I started. You can do all of those things, but if people are living in an environment where their toilets don't work, where they haven't got access to running water, where they're forced to live in overcrowded conditions, it probably you're only going to ever make a difference at the margins. Until you deal with those basic conditions, until you deal with housing, access to all the infrastructure that keeps people healthy, like running water and flushing toilets, unless you provide young kids with access to learning environments that aren't intimidating, that are in language, that are going to mean that children want to go and learn, unless you do all of those things, employment pathways and so on, then no matter what you do with your health service, you're never going to achieve the gains that you need to achieve. So you have to recognise that both things are important, but simply focusing on healthcare is only one part of the puzzle.
Thank you very much. Well, you know, Sami people is Swedish people, and they have, in my region, they have the same equipment as everybody else in the modern world. But thank you very much and I look forward to have a discussion about healthcare for the Indigenous. Thank you.
Thank you. Okay, this side, not GPEW.
The Isle of Man Green Party. Hi.
Right.
In 2014, Mexico introduced a confectionery and sugar-sweetened beverage tax, and now the United Kingdom's announced that they're going to introduce a tax next year. Are your countries, Madagascar, Sweden, Australia, suffering a sugar glut and the associated chronic disease that goes with it, type 2 diabetes, etc.? And how are you responding to it as societies?
Okay, start.
Well, we don't have a tax on sugar actually in Madagascar. And with regards to obesity, it's not seen very often. It's quite rare. Many people do experience malnutrition there, and 40 kilometers away from the capital, there is a pocket of malnutrition. So currently, obesity is not greatly concerning the government or the health ministry. That said, for some time now, we have seen cases of other types of disease, hypertension, diabetes, and hypoglycemia caused by other factors. People eating incorrectly or poor diets, and we consider these diseases linked to obesity ones of the developed rich countries. With regards to this situation, there haven't been laws that have been introduced or taxes on sugar or other foodstuffs that can cause disease if consumed in large quantities. In other cases, in terms of regulations, the legislation isn't tailored completely to the living conditions of the population, so we don't have effective coverage from the regulatory point of view yet of our needs and conditions.
A couple of things to that. Just a couple of things to take away. The first thing is that if you're a child born today, there's every chance that you won't live as long as your parents. Now, we are on the verge of reversing all of the progress we've made in healthcare. Up until this point in time, we have managed to increase life expectancy right across the board. Some countries still lag a long way behind, but we have made incremental progress. We may be the first generation that actually hands down lower life expectancy to our kids. Something's wrong. The second thing to say is this isn't just a problem in wealthy countries. We are now seeing many low and middle income countries, countries like India and China, countries in transition, where the rate of non-communicable disease, that is diseases like diabetes and heart disease, is overtaking the rate of diseases like tuberculosis, malaria, diarrheal illnesses and so on, so-called infectious diseases that were previously responsible for much higher rates of mortality. So this is a pattern that is happening right across the world. You don't need me to sort of bombard you with stats, but just suffice to say that rising rates of obesity result in conditions like diabetes and heart disease. And in medical practice, it's not unusual to see 10-year-old kids coming in with adult onset diabetes. Right? That's happening now in medical practices. The response is there's not one response that's going to address this issue. First thing is the power of the junk food lobby is enormous. They are pervasive. They dominate politics all around the world. They make huge contributions. They're big lobbyists, and they are resisting change at every turn. There are some things that we know work. We need to restrict the advertising and promotion of junk food products aimed at kids. We need to do that as a matter of course. We need to do it quickly. In terms of other public health interventions, we know advertising promotion is one lever. We've seen it in tobacco. But we know that price is also another lever. And looking at a tax on sugar-sweetened beverages, as has been introduced in Mexico, I know you've got one in the UK, there are a number of other jurisdictions, is one response that is likely to have an impact. And so the Greens in Australia have adopted that as our policy. There's some, I think, concern about the impact of that, particularly in terms of people on lower incomes. But it's also important to remember that the impact of sugar-sweetened beverages is felt most acutely on people who have low incomes. And unlike products like tobacco, where we have, as Greens, supported increases in price as a way of reducing consumption, with sugar-sweetened beverages there are alternatives. We know there are alternatives, as I said, unlike tobacco. The revenue needs to be reinvested very directly back into the health system and a range of prevention measures, and if we're to do that, we'll start to, again, make an impact. But this is a real problem. It's a big problem. It's a problem that's happening right across the world, and unless we start to get to grips with it, we are going to find that our kids are dying younger and sicker than we are, and it is absolutely critical that we act, and we act quickly.
So just before Suzanne makes a comment, is Johan or anyone from the resolutions group in the room? I think not. Okay, so what I'm going to do, Suzanne will make a comment on that last question. I think there are 3 questions, so we'll take those 3 questions all together, one after the other, and then I'll give each of the speakers an opportunity to say whatever they wish in response. Okay? Suzanne.
Okay, I will try to sum this up. The Green Party of Sweden has talked a little bit about junk food and sugar tax, but it's not something that we have in government worked for. We have focused very much on climate change and environmental issues in government. What we can do on regional level is to work preventive. In Stockholm region, because healthcare, all healthcare in Sweden is a regional level of responsibility, including university hospitals. So national level don't take in taxes to pay for the healthcare. The responsibility on regional level. So how can you work preventive? For example, we have in Stockholm region a project that we go out, childcare, midwives from childcare go out together with social health care from the municipality and give parents who have their first child an offer that we can come home to you and help you and guide you how to take care of the child. And they started this project especially in a little bit in a more marginalized area where people have lower life expectancy and where people a lot of the people come from other countries. 95% of the parents who had their firstborns said yes to this. So these two, the midwife and one person from the social health care, went to the home of the parents, and what they required was both the mother and the father need to be present. They talk about the child, they talk about how to take care of the child, but they also answer questions about authorities, how it works, how the system, how the society works in Sweden. Where to go for healthcare, where to go for how the parent leave works, how different kind of issues that the parents have about the healthcare system and the social welfare system works and social care works in Sweden. So it's a time in life when you're very open for new knowledge because you want to do the best for the child that just has been born. And that's a good time to talk about how good or bad junk food is and how to eat healthy, live healthy, and exercise and things like that. So this project was very successful. It's in that area, the vaccination rate went up. The use of healthcare actually went down. So it was a win-win situation, both for the parents, the child, and for the healthcare system to work preventive. I also want to about life expectancy, because we talked about that before. My background is that I am a Swedish-speaking Finn. That means I belong to a minority in Finland. I come from a minority in Finland. But this minority in Finland is the only minority that lives longer than the majority. So my life expectancy is 88 years. And that's 4 years in differ from a Finnish-speaking woman that has the same background. That means when there was a study done about why do we Swedish-speaking Finns live longer, they looked on do we have a differ in smoking, eating, alcohol habits, exercise, are we single, are married, what is the educational level? None of this was the significant factor. The significant factor was social life outside of the family, outside of the home. So still when you are 88, Swedish-speaking Finns, women, have a social life outside of the family and meet with other elderly. They still live at home, but they go out to socialize. So if you want to do something good for elderly people, make sure that they are not alone, that they have a social life. 65% of these women sang in a choir. We talked about music here before. Could be one reason, we don't know. But still, the difference between the Finnish-speaking woman and the Swedish-speaking woman in Finland, why they lived 4 years longer was social life.
Okay, thank you. All right, I'm going to have to ask you to be very brief, so should we start on this side?
We have one question.
Thank you.
We are from Green Party of Mongolia. She's our General Secretary of the party, and I'm translating her issue. So her name is Ingma. She's a pediatric and traditional medical doctor, ecologist, and water researchers in the meantime altogether. So she's concerned about the traditional medicine should be spread out a whole country. So Green Party of Mongolia has developed a small project on the establishing traditional medical cluster. So this cluster should be work very efficient and effective way. They help the not for the illness which are very not affordable for the classical medicine. So we would like to ask how do you see on that project? And main problem is that we have not yet financial support in the other government support yet. But this is very important way because she was doing many researches on that way, and she's experiencing has many good own practical experience as a doctor. So this Mongolian traditional medicine is very efficient in way of diagnosing. For example, this diagnosis is using just 6 fingers instead of huge amount of machinery and other computers.
Okay.
So It is, she thinks it is very green medicine and it could be spread out more than Mongolian.
To a wider audience.
Yeah,
yes.
to the
All right, thank you.
other countries.
Thank you very much for that. And over this side?
I'm Birgit Meinhard-Schiebel from Austria, and I'm on one hand the local councillor in Vienna, but on the other hand I am a volunteer and I'm the president of the carer organization in Austria. So I have a question about, maybe I have to explain, we Greens start in 2011 with a resolution in the parliament how to support children between 5 and 18 years who take care for their relatives, for parents, for grandparents, for other relatives. And in two studies, we found more than 40,000 children who do this alone and without any support. So how do you know about these children in your countries? And is there some support for these children? And on the other hand, maybe you have community nursing and they are in contact with the families and with the children, and how can they support these children?
Okay, thank you very much. Okay, so start with Suzanne, then Richard, and finish up with Ratafika. So just a very short. Oh, that question was about how to support children who are who are in a caring role.
Okay, I think I start with Mongolia. For World Health Organization, it's very important that access to herbal medicine, for example, or traditional treatments continue to be accessible for countries who have not developed a state-financed healthcare system, primary healthcare system. And they are very worried for large corporations and companies to take patent on herbs and patent on different substances that are within plants, because that would also make them more expensive and not accessible for countries who don't have a very large medical budget. So this is a concern for the World Health Organization to make sure that it continues to be accessible for you and for all of us in the world. So it's very important.
Okay. Sorry, I'm going to cut you off because we're over time. Richard?
It sounds like it's a candidate for a research project, and I think that's the sort of thing that we should get a well-designed research project and test. And you know, if the research demonstrates that it's effective, then obviously it's a candidate for public funding. But I think that principle of making sure we've got strong evidence before we invest public funds is important. Notwithstanding the idea that regulation around the delivery of health interventions is also really important, as you said earlier, Susanna. Look, I can't add much to that issue of carers except to say it is a significant problem. It's and that is something that I think gets discussed from time to time in Australia. To my knowledge, there's very minimal support for carers. It's particularly an issue for young kids who are caring for one or two parents with mental illness, and that's where I think it's manifested most often. Is often you'll see a young person who has to look after a parent who might have a severe psychotic illness, schizophrenia or something like that, and we don't do anywhere near well enough to look after and support those children, and it has a serious impact on them.
Thank you.
Well, I'd like to continue with regards to what was said by the lady from Mongolia, the Greens from Mongolia. In Madagascar, it's similar. There are many researchers in traditional medicine. They've found many traditional plants that can actually cure what are thought of as incurable disease. They actually have proof of this, and some laboratories are being set up that have been given patents, but at the same time, other researchers have taken the results of their research to developed countries where some of the major pharmaceutical companies are located. And so we wonder whether it's the case that certain medications haven't actually been shown to be effective, or are there certain financial incentives behind the blocking of research, because the products which are the result of research would be more accessible to the poorer and would prevent a major flow of income into those pharmaceutical companies. I'm actually a surgeon, and I've observed many cases of diseases where people are going to be operated on, and we treat them with traditional medicine in the country, and very often this is successful. For example, there was a man who had hypertrophy of the prostate. This was successful. And there was also a child with a lung condition and a lung infection who was treated with an antibiotic-like plant. That is a plant with similar properties to the antibiotic. It actually stimulates antibodies to cure the microbial condition, and after systematic research, we observed the disappearance of those microbes, and the child was cured. And we also tried this with other children, and it was also successful. So this is why I would come back to what I said before. It is possible to easily treat people and cheaply treat diseases cheaply using natural medicine. So a huge amount has to be done at the level of the environment, because it's the environment that produces such medications.
And thank you to our audience for a really extraordinarily broad set of questions and comments, and really a rich discussion. Thank you to the technical people, and thank you particularly to the interpreters. You do just such a fabulous job. And thank you to our three panellists.